And
Thank you very much, Craig, and to the Cooley's Anemia Foundation and to HRSA for making this possible and for inviting me to speak on this topic that is very dear. Can you all see my slides? Okay, perfect. So this is a layout. The idea is to talk about pregnancy and thalassemia. I will be spending the first half going over thalassemia so that we're all on the same page. Alpha thal, beta thal, transfusion, non-transfusion dependent thalassemia. And then how do we relate that when that comes to a man or a woman considering having a child? And then how do we support a woman who has thalassemia, who is transfusion dependent through pregnancy? So we start off with the case. This is that of a 28-year-old woman with beta thalassemia major who's transfusion dependent since 3 years of age, who currently receives about 2 units of red blood cells every 3 weeks and has a pre-transfusion hemoglobin that we're maintaining between 9.5 and 10 grams per deciliter, and she does a pretty good job maintaining that pre-transfusion hemoglobin. She's had a splenectomy at age 7, and when we talk about transfusion dependency, we also talk about iron overload and complications, and she looks like she has a ferritin of about 1,300. Her liver iron is a target at about 5 milligrams of iron. Which is a mild iron in her liver. She has no cardiac iron. She has hypothyroidism, and she also has decreased bone mineral density with a low Z-score of minus 3.5. She had menarche at age 16, but now she has secondary amenorrhea, and she wants to try to have a child. So how would you counsel this patient? How would you manage her? And what are some of the things to consider to help her achieve, to conceive, and then to also safely go through pregnancy? So those are some of the things that come up. You also have a second patient who is a 30-year-old woman of Southeast Asian ancestry. She has a history of hemoglobin H. So she is missing 3 alpha genes and has a baseline hemoglobin of about 10.1 and MCV of 71, a ferritin of 120. She's 10 weeks pregnant. This is her first pregnancy, and what are some of the considerations we need to factor in to help her get through pregnancy safely as well. So I'm going to start from the basics so that we are all on the same page. Different people in the audience have different levels of experience with thalassemia, fertility, and also pregnancy. So I'll try to involve and engage and keep you all interested and learning lots. So thalassemia is a global public health problem. It is an inherited global gene disorder. It is autosomal recessive, primarily found along the malarial belt. We have a high incidence and prevalence of carrier status and diagnosis along the countries of the equator, so Africa, the Mediterranean, the Middle East, the Indian subcontinent, Southeast Asia, and China. But because of immigration, we see thalassemia all over the world. It is the most common genetic disorder in the world. About 60,000 individuals are born annually with a significant form of thalassemia, but we are seeing it more and more in the US population. Thalassemia is due to, when we talk about thalassemia, hemoglobinopathy, sickle cell disease, thalassemia is due to a deletion or a mutation in the globin genes, and it results in a decreased rate of synthesis of one or more globin chains of hemoglobin, resulting in an unbalanced chain synthesis. So we all know hemoglobin is key to the function of red blood cells. Hemoglobin is generally made up of 2 alpha chains and 2 beta chains that work with heme to bind oxygen. The alpha chains are encoded by genes on chromosome 16, the alpha globin locus, where we have zeta and then alpha globin expression. And then on chromosome 11, the beta globin locus, there's embryonic gamma chains, delta chains, and beta chains that are produced on the beta locus. The expression off of alpha and the beta locus is variable across development. So off the alpha locus, right away, alpha globins are produced at 6 weeks of gestation. You see that coming here. So in utero, off the alpha locus, there is alpha globin production. Off the beta locus, however, there is variable expression as we move along the genes. So initially in the fetal life, we have gamma globin production so that alpha 2s will bind gamma 2s, resulting in what we call hemoglobin F. So hemoglobin F is the primary component of hemoglobin, then the red form of hemoglobin, then the red blood in the fetal red blood cells. With variable expression through development, as the fetus develops, and then after delivery, we see over 6 months, the gamma globin production go down, at which point beta globin production increases such that after 6 months of age, the main form of hemoglobin is hemoglobin A, which is composed of alpha 2, gamma 2, and that's hemoglobin A, accounts for about 96 to 98% of hemoglobin after 6 months of age. There is a little bit of delta production, so alpha 2, delta 2 gives us hemoglobin A2, that's 2 to 3.5. So this is what a hemoglobin identification panel would look like for an individual with normal expression of all alphas and all betas. Now, in thalassemia, what happens? So in the erythroid precursors, we have, in the normal circumstance, we have normal production of alpha chains, normal production of beta chains, 2 alphas bind 2 betas, they bind together, and we have normal hemoglobin. However, if there are mutations or deletions in those alphas and beta globin genes, we're going to have decreased production. That decreased production is going to throw off and lead to an imbalance in the alpha and beta chains. So in alpha thalassemia, there's decreased alpha globin production, so there's an excess of beta chains. These beta chains will precipitate out to form these beta 4 inclusion bodies. These inclusion bodies will now precipitate out in erythroid precursors, leading to apoptosis and also cause membrane damage, leading to hemolysis. In beta thalassemia, it's the opposite. Now we've got mutations in the beta globin genes resulting in beta production. Now we've got excess alpha. Those excess alphas will form beta 4 complexes and precipitate out and lead to a much more severe phenotype, where we now know that in thalassemia, what is really driving the pathology is that alpha beta chain imbalance. The more imbalance there is, the more severe the disease, which is driven primarily by hemolysis and ineffective erythropoiesis. And so how does this imbalance lead to complications? The more the imbalance, the more ineffective erythropoiesis, the more hemolytic anemia. That ineffective erythropoiesis drives extramedullary hematopoiesis. The bone marrow says, I need to make more red cells, but what I'm making is all dying in the bone marrow, is not quite making it out. So the bone marrow works harder. It recruits the spleen, it recruits the liver, and it can also recruit erythroid bone marrow along the spine to all continue to work hard to make more red blood cells. However, because of that intramedullary cell death and apoptosis, it's ineffective. So we call this ineffective erythropoiesis, leading to extramedullary hematopoiesis, which presents as hepatosplenomegaly and paraspinal masses. That bone marrow expansion also leads to various skull changes, bony deformities, which leads to decreased bone mineral density and fractures. The hemolysis that these precipitants cause also leads to significant anemia. The more imbalanced, the more severe the anemia, which can lead to poor growth and fatigue in young kids, leading to poor exercise tolerance, poor quality of life, gallstones, splenomegaly. That hemolysis results also in scavenging of free hemoglobin, which can contribute to vascular disease and also hypercoagulable state, which puts these individuals at risk for pulmonary hypertension, thrombotic events, silent cerebral infarcts, and also leg ulcers. I'll go into more details shortly, but one of the key ways to suppress these complications, to prevent these complications, is red cell transfusions. By transfusing normal, healthy red cells, we're raising the hemoglobin, reducing the degree of hypoxia, and thereby suppressing this ineffective erythropoiesis. However, with those red cell transfusions come various complications, including alloimmunization, which can be as high as 20 to 30% in this population, the risk of infections, and then very importantly, which is relevant to the talk today, is iron overload, with iron accumulating in the liver, heart, and endocrine organs. And so just to recap a little bit, when we're talking about alpha thalassemia for the purpose of this lecture today, I am going to focus on those with hemoglobin H disease, since those are the individuals who will have mild, moderate anemia. They may be transfusion independent and may sometimes require transfusions during periods of stress, infection, and also pregnancy is one of them. Okay, the scope of genetic screening and risk stratification, et cetera. I think we all know that, so that's going to be beyond. I will mention that a little bit later. But here in hemoglobin H, we're looking at the deletion or the absence of 3 functional alpha genes, which may be deletional or they may be non-deletional, which in most cases a mutation, and constant spring is the most common one. Hemoglobin H disease, classically, these are going to be individuals who have milder anemia. So we may have many adults who have hemoglobin H disease. Their hemoglobins are 7 to 11. They may have some mild splenomegaly with ineffective erythropoiesis. They may not require any transfusions. However, in pregnancy or in infections, they may have an acute drop in their hemoglobin. And so they may need intermittent transfusions. And that's where it becomes important when we're talking about pregnancy. This is a pictorial that I use, and you'll see this a lot published now in the literature. When we talk about alpha, we talk about alpha thal trait, the hemoglobin H, hemoglobin non-constant spring, and alpha thal major, which are primarily survive due to intrauterine transfusions. When we talk about beta thalassemia, we have 2 beta globin genes. You can have a null mutation with beta 0 or beta plus, where the mutation is still resulting in some beta globin off that locus. So we know beta thalassemia trait have borderline asymptomatic anemia with some microcytosis. And then at the other extreme are those individuals with beta thalassemia major, where they present early, usually in the first year of life, with severe anemia, hemoglobins of 6, and are transfusion dependent, starting at a very young age to survive. And then there's this big category of thalassemia intermedia, which can be due to various different mutations, beta 0, beta plus, other modifiers. So if an individual had beta thalassemia trait, but they also had alpha duplications, now there's more alpha imbalance, they can present as a severe thalassemia intermedia. And these are generally, thal intermedia individuals are generally individuals who make it through childhood without regular transfusions. They present later in life. But as they get older, their hemoglobins generally drop, and they can convert from not needing transfusions to requiring transfusions to prevent complications and improve quality of life due to anemia. So if we go back to our pictorial, this is a nice summary slide in terms of how we describe thalassemia. The modern way is we try to categorize it based on transfusion dependence. So transfusion dependent thalassemia, TDT, and non-transfusion dependent thalassemia. So at one spectrum, there are individuals with no transfusions. At the other are those with require transfusions to survive. In the middle here, you'll have those who might need them intermittently, pregnancy, infection, versus those who may have started on the left and then require transfusions as they develop symptoms and they progress. So in this category, with the non-transfusion dependent, and then those who are requiring transfusions every 3 to 4 weeks would be described as transfusion dependent thalassemia. So when we talk about beta thal trait, they fit at this end. Beta thal intermedia and also hemoglobin E, which is another variant seen in Southeast Asians, present with non-transfusion dependent thalassemia most often. And then you have the beta thal major. And then we went over alpha thal. So I'm going to spend a little bit of time now talking about beta thalassemia major. These are going to be individuals, some pictures here of that frontal bossing due to expansion of the marrow in the skull, and the form of due to ineffective erythropoiesis, hepatosplenomegaly, and this shows paraspinal masses that are all hematopoietic tissue in individuals who are if they're not transfused, or they're suboptimally transfused, you're getting more of that bone marrow really working hard to try and make more red cells. And so the key goals for management in transfusion-dependent thalassemia is first to correct the anemia and then to prevent the complications of that ineffective erythropoiesis. So we don't get splenomegaly, we don't get bony changes, we don't get paraspinal masses. And so in beta thal major, we generally start transfusions around 1 year of age. Generally, as adults, transfusions are so do it in kids, it's transfusions every 3 weeks. It's going to be weight-based. Your general adult is going to receive about 2 units of blood every 3 weeks to maintain a pre-transfusion hemoglobin greater than 9.5. At this level, it's enough to suppress that ineffective erythropoiesis and prevent complications. For those who don't transfuse a lot in thalassemia, I just want to keep in mind, this is a pre-transfusion hemoglobin of 9.5, meaning that the lowest hemoglobin we want them to see is 9.5. So if a patient came in on their transfusion day and their hemoglobin is 9.5, we still want to go ahead and give them that 2 units and stay on this regimen of 2 every 3. If they happen to be 8.8 that day, well, we might give them a little bit more blood. We may give them 3 units, or we may bring them in at 2 weeks instead of 3 weeks. But the importance to stress is that is the 9.5 is the lowest they should be seeing. That iron, that blood we give does lead to iron overload, and so the need for chelation. Each unit of blood carries about 275 milligrams of iron, and the body doesn't have a way of getting rid of that iron. That extra iron, when it's now transferrin is saturated, floats around in the form of non-transferrin bound iron, which then accumulates in various different organs, the pituitary, the parathyroid, thyroid, heart, liver, pancreas, and gonads, and there results in apoptosis and organ damage. This is old data now, which is really valuable in individuals who receive transfusions but do not receive chelation. So this is data from the 70s. They develop liver fibrosis by age 5, delayed puberty, diabetes, hypothyroidism by sometime between 12 years of age, and heart failure by about 14 to 15 years of age. So many of our individuals who are now thinking or who are now in their 40s, 30s or 40s, many of them, or even 50s, were told that they would not make it past their 18th birthday. We look at complications. This is published in 2004. So these are, this is at a time when there's less chelation. This is Italian data that we see that hypogonadism is the most common complication in those on chronic transfusions, and cardiac death due to cardiac iron overload was also the most common cause of death in transfusion-dependent thalassemia. This is a summary of the organs that are affected. The most commonly affected is the liver. Iron accumulates in the liver as a storage organ, so that's the first place the iron goes. The iron also goes when the liver is saturated, will go to the pancreas and the heart. For today's talk, the key point here is also the pituitary. The pituitary is a very small organ, so it doesn't take very long to damage the organ, and leading to hypogonadism and then other endocrinopathies that follow after. And so it's very important in order to prevent those complications. We saw early endocrinopathies, hypogonadism. And so how do we prevent that? We need to monitor the amount of iron that's accumulating, and that'll allow us to then chelate effectively. So we monitor the iron through serum ferritin, liver MRI, and a cardiac MRI. So here you can see this is an MRI of the liver. It's very dark. There's lots of iron here. There's nothing in the heart. Here you've got your left ventricle, the septum. There's lots of iron there, but no iron in the liver. It's really important to do those together. And then we do have chelators where we have subcutaneous desferal, and then now we have access to oral agents. So what do we follow? We generally try to keep a serum ferritin less than 1,500. If that even better is less than 1,000 for our patients. So a serum ferritin less than 1,000 is associated with better outcomes. When it comes to liver iron monitoring, we use an MRI R2 or T2 star, and we're aiming for a liver iron content of 2 to 5 milligrams of iron. We really want to get that number, not just a subjective, oh, there's iron. We want to know exactly how much, because that'll allow us to then predict for fibrosis, cardiac iron, and also allow us to taper our chelation or adjust our chelation. Cardiac, this is again, the cardiac iron, we use a cardiac MRI T2 star. Our target is to keep that T2 star over 20 milliseconds. We know that those with a T2 star less than 20 have an increased risk of developing heart failure. This is just a very similar picture to what I showed before. The key point being that if somebody has never had an MRI of their liver or heart, you can get differential loading and unloading of iron in the organs. Also, different chelators that somebody may have had can also affect the different organs. And so it's always important to do both of them together, especially if you're doing it for the very first time. This is a table that just shows and is very significant here for our population, a woman who's pregnant. A cardiac T2 star predicts the risk of developing heart failure. So over 20 is normal. You see that if the T2 star is between 10 to 20 milliseconds, there's up to a 10% per year risk of developing heart failure. It jumps dramatically when that T2 star is 6 milliseconds or less. The risk of developing heart failure in a year is between 38 and 70%, and therefore the need for aggressive chelation. This is a summary of our 3 chelators. The 3 chelators here, we have the subcutaneous desferal. This is the longest one that's available. It's a bit of a nuisance, but this is one that is that we used to use before. Now there are indications, and there is definitely a role for this. I'll come to the 2 oral chelators now. Deferoprone and Deferasirox are standard. Most of us will start with Deferasirox, either oral suspension or the film-coated tablet. Mostly the film-coated tablet. It does a really great job of removing iron from the liver, and can also remove iron from the heart as well. And I'll leave that summary there for your reference in the future. This is a pictorial here again of the rates of endocrinopathies, primarily due to iron overload. You'll see hypogonadism seen in anywhere from 35 to 55% of patients, decreased bone mineral density as high as 90%. And so the key to managing transfusion-dependent thalassemia involves maintaining a pre-transfusion hemoglobin between 9.5 to 10.5, checking the serum, every 3 months serum ferritin, yearly liver iron, and cardiac MRI T2 star after 10 years of age, aggressive chelation, and then monitoring, screening, and treating end organ complications through multidisciplinary care. Through all of that initial graph that I showed you, where the survival and risk of heart failure was high by 15 to 18 years of age, that is significantly changed due to advances in transfusion, safety, infection, better monitoring for iron overload, and better chelators, plus multidisciplinary care. We see a dramatic decrease in the number of deaths in thalassemia. Our patients are living longer. The cohort that is born in 2000, this is UK data, has more than 80 to 85% chance of making it over their 40th birthday. And I will say that number is getting even better. So this improved survival is offering many opportunities for our patients to think about starting a family, to think about careers, relationships, and eventually having a child. And when we think of our population, we advocate right from pediatrics. We say you chelate, because by removing that iron, we're reducing the damage to the pituitary, and we're allowing women to continue to cycle, and preserving their fertility. But I want to draw your attention to this. Through the course of of evolution of the care, we have different cohorts of patients. In my practice that ranges from 18 to 60 years of age, those individuals who are in their 30s and who are in their 40s and 50s were never able to have kids. There are 30, 40-year-olds due to iron overload have primary amenorrhea. And then we have our younger individuals who cycle and their axes seem to be normal. This is just a quick slide on non-transfusion dependent thalassemia. I think I've alluded to this a little bit. These are those individuals who have milder forms. They have milder anemia, and they may require transfusions intermittently due to worsening anemia during infection or pregnancy. However, we also know that many of these individuals who may not have required transfusions when they were younger, as they get older, that hemoglobin drops, that spleen's getting bigger, they may develop pulmonary hypertension, decreased quality of life, in which case those individuals may transition to becoming TDT, where they now need transfusions to prevent those complications, very similar to our TDT population. So hopefully we're now all, we've had a chance to update ourselves or learn some of the nuances and really the impressive advances in the care of individuals with thalassemia, where our young women and men are growing up and they are the option of having children is very real and very possible. And so I'm going to touch first on fertility. This is looking at primarily Italian data that we see that, and this is going to be older data too, that secondary amenorrhea and hypogonadism is very common. Of all the endocrinopathies, it's seen in about 50% of patients, and the serum ferritin level is a good predictor of hypogonadism. So the higher the ferritin level somebody had, the more iron they had, the more higher liver iron they had, the more likely they are to have hypogonadism. However, what we do know is that when we talk about pregnancies, this is the Thalassemia Clinical Research Network, who had done initially a study in looked at their cohort in a publication back in 2004, where pregnancies were only seen in about 8% of patients. Now, a recent update in 2013 looked at the cohort, and we see that number of pregnancies increasing from 8% to 25% of women being able to conceive. What we do know that pregnancy is more common in women with normal menses. So women who have normal menses, that's assuming that they were well chelated, they were able to keep their menses going, are able to conceive more easily. And then those with secondary amenorrhea were less likely to be able to conceive. And this is Italian data. From the UK retrospective data, when we look at thalassemia major, transfusion dependent versus thalassemia intermedia, we see that more women with thal intermedia had pregnancies compared to those with thal major. Here being also that the thal intermedia patients have less iron overload and thus are still are less likely to have hypogonadism. We also, this data also shows that women needing assisted reproductive technologies to conceive were generally older and also had thalassemia major transfusion dependence. What is encouraging from data and also real world practice, from what I see in my practice, is that spontaneous pregnancy can occur in our well transfused and well chelated patients. So many of our patients in their 20s and 30s have been through that generation of new monitoring, new cardiac MRI since 2000, better oral chelator, better understanding of thalassemia. And so many of the well chelated, well transfused patients are able to conceive without the need for assisted reproductive technologies. What we also know from data is that pregnancy is safe in most women with thalassemia major and thalassemia intermedia when it is planned and when the patients are well chelated. So this is just going to be an overview. There may be many of you in the audience who know more of this, but this is again to keep us all in the loop here. So when we talk about the gonadal axes, we talk about the importance of the pituitary, the importance of the pituitary and production of LH-FSH, stimulating production of estrogen and progesterone, and what we see is that in iron overload, the high pituitary iron, there's shrinkage of the pituitary, leading to hypogonadotropic hypogonadism, also which will lead to decreased ovulation. But also, there is evidence that iron accumulation in the ovaries also results in production of increased oxygen, reactive oxygen species that also reduces ovulation. When we look at male, again, the same physiology, the high pituitary iron with shrinkage of the pituitary and hypogonadism, resulting in decreased sperm production due to less decreased signaling. But there's also more damage happening in the testes. So we know that high iron in the testes, the high systemic non-transferrin bound iron, the high reactive oxygen species. There's also increased sperm DNA fragmentation, resulting in both decreased sperm number and also decreased motility. So in males, it's both pituitary damage, but also much more damage to the testes and spermatogenesis as well. And so when we are talking about fertility for a young couple, it's really important to start fertility assessments and evaluation of both partners in thalassemia. We recommend starting if a couple is unable, if a woman has periods, pardon me to the OB-GYN folks, but if a patient it has normal periods. However, a couple is unable to conceive within 6 months. We say we should be evaluating them for referring them to fertility evaluation, etc. For women who do not have periods, either with primary or secondary amenorrhea, we really want to be starting a fertility evaluation early on by a fertility specialist. It's important that we start this process for both partners early because it's really important and I can't stress enough the importance of pre-pregnancy counseling of the couple to determine the risk of having an affected child, but also to begin to start caring for the patient who's a woman with thalassemia, where we are now going to need to also make sure that the thalassemia is well managed to reduce the risks of complications. This is an overview of some of the testing that a reproductive endocrinologist would do. Measuring, checking the FSH, LH, E2, and testosterone levels. Females generally get pelvic ultrasound and tubal patency testing. Males get a semen analysis and a testes ultrasound. And then also the importance of hemoglobin identification for genetic counseling is needed. We know that in most women in thalassemia, most women may have primary amenorrhea with no periods or secondary amenorrhea where they have periods, but then they stop. Most of these women will need assisted reproductive techniques. Even though up to 90% of patients may have hypogonadotropic hypogonadism, the ovaries and the testes are still intact. And so we're able to stimulate ovulation and sperm production. And so there are options because it's primarily, it's a pituitary defect, but their ovaries and their testes should still ideally be able to function and be able to, induce ovulation. There is some data done by our colleagues out west, Dr. Singer, who looked at some ovarian reserve. And so fertility evaluation involves this. We do know that there's low ovarian reserve in women with thalassemia. Those with low ovarian reserve have a lower chance for spontaneous pregnancy. They also have a poorer response to hormonal stimulation. And so there's an ultrasound that's done looking at the antral follicle count. We know that in thalassemia, so first in general, as women age, their AFC decreases. This graph here shows, the red line, that in thalassemia, it's much more worse. They already have lower numbers of follicles, and they also go down, the numbers go down faster. So they have lower follicles to begin with. And then we also evaluate with an anti-Mullerian hormone, which assesses the ovarian follicle pool, and that's worse again in those with iron overload. A male individual with thalassemia will have a semen analysis, and they're just keeping in mind that there are other multiple causes for low semen counts, including iron overload in the pituitary, iron in the gonads, and then many other environmental factors that may be contributing in there. Those are things that a reproductive endocrinologist would be factoring in. What was really cool was on this paper I found that transfusions in those with thalassemia increases increases sperm count and also motility. So you see here, they looked at hemoglobins, and they were able to, they looked at those who are transfusion dependent and looked at the hormone levels, the sperm counts, the motility at baseline, and then 7 days after transfusions. And when the hemoglobin was higher, you saw these numbers improve as well. So stressing the importance of optimization of their transfusion regimens and really trying to make sure that pre-transfusion hemoglobin is over 10. In the interest of time here, this is just an overview of what the different options. So when we're talking about induction of ovulation, again, this is done primarily by the reproductive endocrinologist, but we can consider induction of ovulation in those with primary or secondary or amenorrhea or oligomenorrhea. A woman who has a normal menstrual cycle who fails to conceive, and also the induction of ovulation when we need to plan a pregnancy with IVF when there's a risk of having an affected child. And then induction of ovulation and spermatogenesis there's different drugs that are used and different protocols. But here we're inducing with gonadotropins or pulse GnRH. And for females, there's also the option of clomiphene. Conception can be either through intrauterine insemination, in vitro fertilization, and IVF with intracytoplasmic sperm injection, especially when there's a pre-implantation genetic diagnosis when a couple is at risk for having an affected child. So the key here is really to engage the reproductive endocrinologist early on so that all of these options can be discussed. When we look at males and females who've required ART. This is a report from the UK about a 15-year experience of 30 couples who had 28 pregnancies. And we see that when we're looking at females and induction of ovulation with gonadotropins, there was an 80% success rate within 3 cycles. However, when we look at spermatogenesis, the males overall had a lower success rate of only about 10 to 15%. It's a much more drawn out, longer process for males. We do know that fertility is possible because we have in this population and in the study, they have preserved ovarian and testicular function. So it's about induction of ovulation and spermatogenesis. And overall outcomes were better in females than in males. And so the key is, again, chelation, adequate chelation. So we preserve the gonadal axes. But when we talk about fertility options, and these are discussions that the reproductive endocrinologist is going to have, it'll depend on the site of damage to the HPG axis. So in our population, so when there's hypothalamic pituitary failure, as we see in our population, that you can induce ovulation or induce spermatogenesis. There may be also primary ovarian or testicular failure, in which case there's egg or sperm donation. And then it'll also depend on the carrier status of the partner. partners. So if both partners were homozygous, then we may, you may need to consider a sperm or egg donation if the goal is to not have a child with significant form of thalassemia. If the partner is a carrier, there's an option for pre-implantation genetic diagnosis. And one of the things I always stress in my practice is that adoption is always an option in all cases. I'm going to move on to pregnancy and thalassemia, spend the last little bit. So the first case that I had presented was that of an individual with thalassemia major who had a ferritin of about 1,300, good liver iron, no cardiac iron. And the best outcomes in pregnancy, we've seen that pregnancy can happen. It can be spontaneous. We can use ART. But the best pregnancy and the safest pregnancy is when it's a planned pregnancy. There are a few risks to the mother. The biggest one is cardiac function. In those with pre-existing cardiac dysfunction, with high iron burden and the transfusions, they can be cardiac complications and even death. There can be a development of new endocrinopathies, especially if there's already high iron overload. That can get worse during pregnancy, especially because the transfusion requirements may go up. The ferritin does increase by about 60% in women during pregnancy. There are increased rates of C-section, increased risk of thrombosis, and then there's data for increased anxiety and depression. Risks to the fetus, there's no increased risk for miscarriage or malformation. However, there's a 4 to 8% growth restriction, preterm labor, and then risk for multiple births, primarily those would be assisted reproductive ART. There's a really beautiful piece of work that was done. This is published in Blood Advances in just a few months ago. This is a systematic review and meta-analysis looking at all the publications in thalassemia major and intermediate, looking at pregnancy outcomes and correlating them with the iron status. There isn't a lot of what's out there are case series and a cohort study. They looked at 429 subjects with 684 pregnancies, mostly were single centers. There's a mix of only thal major, only thal intermediate, and then papers or centers or published papers that looked at both. These range anywhere from 1989 reports to 2017 reports. And what they found that in this cohort, if you compare thalassemia major and thal intermediate, so thal major would be the transfusion dependent versus non-transfusion dependent, what was really dramatic was a huge increase in thrombotic risk in the non-transfusion dependent patients during pregnancy. What they also saw that was dramatic is a preterm birth in those with transfusion-dependent thalassemia with requiring NICU admission, primarily due to the pre-birth. When we looked generally, when they looked at the cohort, and this is generally the consensus, a pregnant patient with thalassemia, the goal is to maintain a pre-transfusion hemoglobin over 10. This is due to increased requirements, and the general consensus is keep that pre-transfusion over 10. What we do see is that there is an increase in transfusion requirements from 102 milliliters all the way up to 139 milliliters when we're looking at blood volume. Generally, a patient who's not pregnant gets 2 units every 3 weeks. Very often in a pregnant individual by the end of second, third trimester, because of the volume, symptoms, they may require transfusions of 2 units every 2 weeks. And so the requirements do go up. We also, from this paper, they also, in their population of non-transfusion dependent thalassemia patients, 70% of them needed transfusions during pregnancy. And so I want to go over the preconception counseling. So we have this data of what some of the complications can be. One of the key complications that I should have mentioned is also cardiac, and I'll come to that. And so when we're evaluating a patient, so the case that I presented, can somebody conceive? What is the preconception counseling that we want to counsel our patients? And the first one is really aggressive chelation. Guidelines talk about aggressive chelation to get that liver iron less than 5, get that T2 star normal over 20. And then definitely doing a cardiac evaluation, including the EKG echo Holter and a T2 MRI, and having cardiology evaluate them. So we want to embark on a pregnancy when we have no cardiac iron, normal cardiac function, and no liver iron. We also want to make sure that all the other endocrinopathies are also optimized. Low heart function, so a low ejection fraction, is a contraindication to pregnancy because of the increased mortality risk in those with heart failure embarking on pregnancy. Preconception counseling also involves assessing for complications, so optimizing the endocrinopathies, first screening and then managing the diabetes, hypothyroidism, optimizing bone health, optimizing the transfusions, also the viral status and vaccinations, ensuring normal liver function, and also optimizing blood pressure. And so when I generally start these conversations early on so that we can optimize, especially the iron burden. What is also important is preconception is also medication adjustments. Oral chelators, so deferasirox and deferapro, are contraindicated in pregnancy. And so that's another reason to optimize chelation, get that liver iron as low as one can get in the 2 to 5 range before we embark on pregnancy. For the most part, if somebody has no cardiac iron, no liver iron, we stop all chelation during pregnancy. Bisphosphonates, if somebody is on, we want to discontinue them 6 months before. We stop hormone replacement therapy. If somebody is on an ACE inhibitor, we want to stop that. And then also the importance of folic acid 3 months preconception. This is for completeness. This is the preconception genetic screening, partner screening, and testing and counseling to determine the risk of having an affected child. And so the key point to stress in the preconception was to optimize transfusions and optimize iron burden so that we have minimal iron on board. During a transfusion, during a pregnancy, we maintain a pre-transfusion hemoglobin over 10. These are increased in second and third trimester. Those with NTDT may require transfusions to allow for normal growth and development. Because the general consensus is to hold all chelation during pregnancy, we do see that the serum ferritin increases during pregnancy. That same meta-analysis showed that in transfusion thal-major patients, the ferritin increased by about 1,000. And what we also see is that the liver iron, when we're not on chelation, the liver iron, in their cohort went up from a mean of 4.6 to 11.9. The cardiac, because we all started with a good cardiac T2 star, it does drop a little bit, but for the most part, it's still over 20. What we do know is that during pregnancy in TDT, there's increased left ventricular end diastolic changes. There's a fall in ejection fraction. That chronic anemia also puts more stress. There's increased systemic vascular resistance. There can be left ventricular dysfunction. And there's a decreased cardiac reserve due to the non-transferrin bound iron that's floating around. And cardiac complications remain the primary cause of death in TDT, therefore stressing the importance of cardiac monitoring and optimizing cardiac function before. Okay. One of the key things is there's old data. Thankfully, I don't think we've seen too much of this now, especially in places where we have good access to care. But there are reports of 2 deaths during pregnancy from overt heart failure. Those were individuals who had cardiac iron, who had high liver iron. And so again, we want to optimize, can't stress enough, optimizing liver and cardiac iron before embarking on pregnancy. So chelation, all chelation is teratogenic in the first trimester. So we do not, so all chelation is stopped before pregnancy. There are no oral chelators used during pregnancy. If somebody does have severe iron and they conceived, we may start desferal in the second or third trimester if there's severe liver or cardiac iron. Individuals, there's been some data from Dr. Singer et al. Out west at UCSF, where they did show that there was no fetal toxicity when desferal was used in the second and third trimester. Deferoprone and dipiracerox have been shown to, in animal models, to be associated with toxicity, and so therefore they're avoided in pregnancy. So the key is that iron overload story I keep talking about, keep making sure we chelate before. And this is just a summary. So in somebody who has no liver iron and no cardiac iron, they do not need chelation. We can then aggressively chelate them after they deliver. For those who do have cardiac iron and who do have liver iron as well, we can consider deferoxamine in the late second or third trimester. Prenatal care is a multidisciplinary approach with cardiology, endocrinology, thromboprophylaxis with aspirin if they've never had a blood clot before, and then closely monitoring with MFM. Just in the interest of time here, for the labor, timing, and methods for obstetric or follow obstetric guidelines, we again aim to keep the hemoglobin over 10 grams per deciliter. There are some centers that use peripartum chelation with a desferal infusion during labor. If you're starting out with no cardiac iron, I think, this gets really complicated to try and do desferal when labor is happening and it's already chaotic and then the importance of continuous electronic fetal monitoring. Postpartum, there aren't very good guidelines, but consensus is for DVT prophylaxis for the first 6 weeks after delivery. Desferal is okay in breastfeeding. It's secreted in the milk, but it's not absorbed, and there's no safety data on oral chelators. And then I usually repeat a liver MRI, cardiac MRI, usually 6 to 8 weeks postpartum. And then that helps guide me in terms of my chelation and when I want to start chelation thereafter. So to summarize, I think I can't stress enough the importance of a planned pregnancy. But even before that is to chelate, to reduce iron burden so that we can preserve gonadal function, allow for pubertal development, fertility preservation, and then a safe pregnancy. There are many options of starting a family, so just keep that in mind. Start early counseling. And then when we're thinking of pregnancy is to reduce the amount of liver and cardiac iron. These are some of the resources that are available, and you can refer to those. So I know I spoke a lot. Hopefully you found this helpful. I'm happy to take any questions. This case here, hopefully we walked through some of the criteria, but I'm happy to take any questions.
Thank you very much, Dr. Sayani. That's an incredible presentation, so much information, so much valuable information there. I can't thank you enough. Does anyone have any questions? If you do, please feel free to put it into the chat box or to unmute yourself and ask the question live and in person. While we're waiting, I just would ask Dr. Sayani, because there's a lot that you mentioned about the importance of the liver iron concentrations and the cardiac iron both being measured by MRI. And for those people who perhaps don't have a lot of experience with thalassemia, is there anything they should know about, how easy or difficult it is to get those kind of MRI measurements for heart and liver iron?
Yeah, so that's an excellent question. So your typical MRI that you do in your liver abdominal MRI will comment on, yes, it looks a little dark. There's evidence of iron in the liver. That's not good enough. We want to know exactly the milligrams of iron. In the past, we used to do liver biopsies, and with now newer MRI technology, we can correlate the R2 and the milligrams of iron. So there are several options. There are published formulas that some radiologists can use. But there is a Fariscan, which is a company, Resonance Health, that there is a website. They use R2 technology. There are many centers around the country that offer this. And it's the FDA approved way to look at liver iron quantification. But I think reach out to, you can reach out to the thalassemia centers, the Cooley's Anemia Foundation, but also speak specifically to your liver MRI teams. Many of the MRI companies now have built-in formulae that helps the radiologist give you a quantified milligrams of iron per gram dry weight. So you want to make sure you're getting an accurate MRI reading. So definitely speak to your radiologist. For cardiac MRI, it's pretty standard across. I think they've done a much better job. You want to get a cardiac MRI non-contrast, but you want to also specifically ask for the T2 star that is measured at the septum, the mid-septum. So that's available, much more widely available. So definitely reach out to your radiologists.
Thank you. Are there any other questions?
If I may just add to that, the one thing is I do a lot of special authorizations for this. So why do you want a cardiac MRI on this patient? Have you done an echo? What did the echo show? And so the key here is there is good data. But the key is by the time we wait for echo changes, the iron is already severely high. Right. So we need to get that cardiac iron. And one of the things I say is if I send the data and I was like, knowing the exact number of liver iron, the exact T2 star allows us to then tailor our chelation, whether we use deferasirox or deferoprone. They all have different affinities for iron in the different organs. And so that's one challenge you may face. And that's kind of what I do in my peer-to-peer conversations is we do not want to wait for a low EF to start. We need to know these values before.
Thank you. All right. Any last questions? All right. If not, I would like to thank everyone for joining us today. And a special thank you to Dr. Sayani. That was really an impressive and presentation, which gave so much information that I think is incredibly beneficial, especially for those who may not have a familiarity with thalassemia coming into this. And I want to thank you for helping us and sharing your expertise this way. If anyone does have any follow-up questions that they think of later, please feel free to send them to me. I'll put this into the chat box. The letter C, Butler, at thalassemia.org. And if you have any other questions or need to know anything else that we can help with, please feel free to let us know. And I will say thank you again, and we look forward to hearing from all of you. Thank you, Dr. Sayani.